This CLDF podcast is supported through an educational grant by Salix.
Hi everyone, welcome. So we're at the 6th annual Liver Connect meeting today, and we're going to be talking about the management of portal hypertension. So the first kind of area that we're going to be covering is looking at the role of non-selective beta blockers, particularly carvedilol versus propranolol, and really comparing their efficacy in terms of preventing the first variceal bleed. So when we talk about management of portal hypertension today, the conversation has really shifted from just preventing the first variceal bleeding event to now really preventing decompensation overall. And a central question that often gets asked in primary prophylaxis is which non-selective beta blocker we should be using, whether that's carvedilol or propranolol. Now, mechanistically, carvedilol has an advantage because it blocks both beta 1 and beta 2 receptors, reducing cardiac output and splanchnic inflow, but it also blocks alpha 1 receptors, lowering intrahepatic resistance. Now, this dual mechanism produces a significantly greater reduction in portal pressures compared to propranolol. So a lot of hemodynamic studies that have been done in this area show a larger hepatic venous pressure gradient reduction with carvedilol. And importantly, many patients who are deemed non-responders to propranolol end up converting to responders when switched over to carvedilol. Clinically, carvedilol has demonstrated lower rates of first variceal bleeding compared with endoscopic band ligation in randomized trials and long-term studies such as the PREDESI trial, which showed that non-selective beta blockers not just reduce hepatic decompensation, but also improve mortality in patients with clinically significant portal hypertension. And so the current guidance from AASLD supports carvedilol as first-line therapy, particularly in patients with high-risk varices. And the typical target dose is about 12.5 milligrams daily, and anytime we kind of push beyond that, it tends to increase the risk of inducing hypotension without any additional portal pressure benefit. So if you were to ask me, consider propranolol in select patients where you're struggling with borderline blood pressure or mean arterial pressures. But otherwise, all patients with compensated cirrhosis, with or without clinically significant portal hypertension, carvedilol should be your default. Next, we're going to talk about the Baveno VII criteria and really seeing if applying the non-invasive quote-unquote rule-out criteria to reduce frequency of screening endoscopies. And so a major advance that has happened in the field was the application of the Baveno VII criteria, which really has allowed us to safely avoid unnecessary screening upper endoscopies using a lot of the non-invasive tools that we have available. And so clinically significant portal hypertension, which is what we worry about the most, can effectively be ruled out if you have a liver stiffness of less than 15 kilopascals on a vibration-controlled transient elastography and a platelet count above 150,000. And the negative predictive value of that is extremely high, nearly 99%, meaning these patients really do not require screening upper endoscopies. Now, conversely, clinically significant portal hypertension is much more likely if your liver stiffness exceeds 25 kilopascals or if there's intermediate stiffness values accompanied by thrombocytopenia. And so in borderline cases, when available, we're also able to use spleen stiffness to further refine our risk stratification criteria. And this approach really has dramatically allowed us to reduce the endoscopy burden while maintaining safety for our patients. Now, one thing to keep in mind is that there are certain subtypes or subpopulations of cirrhosis, particularly those with MASH-related cirrhosis with concurrent obesity, where this criteria may not apply as well. And so alternatively, risk models such as the Anticipate NASH may perform better in predicting if whether or not these patients may have or may not have varices. And then lastly, the topic we're going to touch upon is essentially managing what we call the beta blocker window, which is recognizing when to stop non-selective beta blockers in patients with refractory ascites or even hypotension. And so as we kind of think about this, it's important to understand the concept of what essentially the beta blocker window is. And so non-selective beta blockers provide significant benefit during compensated and early decompensated phases of cirrhosis in terms of reducing portal pressure, which translates to fewer hepatic decompensation events and improves survival. And so historically, the therapeutic window began only when we saw evidence of clinically significant portal hypertension. However, there's been a massive shift in the paradigm now, and we now consider these medications as soon as a patient is diagnosed with cirrhosis, whether or not they have portal hypertension, rather than essentially waiting for varices or a bleeding event. And so then the question becomes, okay, well, we've now figured out when to initiate the medications. And the question becomes, when do these medicines need to be stopped? Essentially, when does the beta blocker window close? And so that is really driven by when your systemic hemodynamics can no longer tolerate further reductions in cardiac output or arterial pressure. And what essentially happens at this point is that the risk shifts from portal pressure benefit to impaired renal perfusion and circulatory dysfunction. And so some of the signs that we should be looking out for to identify this is when a patient's systolic blood pressure consistently starts becoming less than 90 millimeters of mercury, whether you're evaluating them in the outpatient clinical setting or on the inpatient side. If you're getting mean arterial pressures less than 65 millimeters of mercury, your sodium levels are now less than 130 consistently, or you start seeing a rise or persistent elevation in your creatinine of greater than 1.5, and then clinically symptoms you're looking for are refractory ascites with persistent hypotension. In any of these scenarios, the default should now be to either reduce the dose or discontinue the medication entirely. Now, in certain scenarios, one can make the argument that we can try switching to propranolol or nadolol, since they have less of an effect on the arterial pressure. But again, these decisions need to be individualized based on the patient in front of you. And with that, that is our end of the discussion around management of portal hypertension. Thank you so much for listening. And for more information, please visit the Chronic Liver Disease website. Thank you.